and people go, oh my gosh, I have no idea this is what a normal person feels like after a meal. And so they had what they had thought was normal was just something they had experienced their whole life, was that they would eat and they would have bloating and cramping and pain. They just assumed that everybody has bloating and cramping and pain after a meal. And it wasn't until they cleared out the bacteria in the small bowel and they treated that small bowel overgrowth that they were like, oh, no, that actually isn't a normal thing for people to feel. Welcome to the Pray Health and Wellness Podcast. This is podcast number 15, and my name is Dr. Jeff Davis, and I have with me Dr. Kristen Marvin.
Hello.
This podcast, by the way, is not sponsored by Element, but Element, if you would like to sponsor the podcast, please reach out.
Yes.
And I'm getting over a cold, so I apologize if I cough. I feel great. I just feel like my lungs are doing some housekeeping. So
getting stuff out still.
Yeah, there's a little bit of that.
It's always a good thing.
So the topic that we're talking about is gut health. And it's funny because our presentation today, our provider meeting, we actually presented, I think, a really fascinating case on gut health. And there was it just reminds me, there's so much going on in the gut.
Yes.
And I think I think the medical field is just still scratching the surface with what the gut does. To me, it's amazing that we have more cells that are bacteria in our body than we have cells that are human.
Yes.
Which is just...
So who was it that said, I think we were at like some conference and somebody said, so really, are we just bacteria having a human experience?
Exactly. I've heard another person explain it. They said, we're kind of just a meat bag walking around for our bacteria so we can transfer. God. But if you think...
I like the first one better.
Well, and also what's amazing is think about where our bacteria comes from. I mean, when we're born through the vaginal canal, most of us, I mean, some are C-section, but even the C-section babies now, there are some protocols where they're taking vaginal swabs and swabbing the nares, so the nasal cavity and the mouth of the baby when it's born. And so we're picking up that maternal bacteria from our mothers, and we really don't know what else is being communicated with that. I mean, those bacteria have a memory. They have a heritage.
Yeah.
Some of that's coming around. So I think all that to say, we could probably spend hours and hours and hours talking about the gut. So this is going to be, I think, more of a high level, what do we mean when we talk about gut health? What are the things we focus on? What is our gut really doing for us most of the time? Thankfully, most of us don't have to think about our gut on a daily basis, but some people certainly do. So yeah, I think I'm humbled. I think this is another area where you feel like the more you learn, the less you know. Does that make sense?
Yes, absolutely. Because like you said, it seems like the medical community knows just a fraction. And on one hand, I think we do have some really cool research, right? Several studies that have been published, the microbiome project, things like that. But also, to look at it through another lens, I think the unfortunate reality is a lot of conventional, medical training doesn't even really talk about stuff like this very much.
Yeah.
A lot of medical students are just like, we're not learning about the gut microbiome or, how maybe our gut health impacts other areas of our health too.
Right.
Like our immune system, our hormones, the gut-brain connection.
Totally.
So many things. So again, good to stay humble and acknowledge that we ultimately probably still only know a fraction of what there is to know. But also that we can use some things that we think we do understand to try to help people achieve optimal health, right?
Yeah, I'd say it's an exciting place to learn. It's an exciting part of the body to learn about because you can, if you learn about something on the weekend, you can the next Monday usually apply that to your patient.
Mm-hmm.
And I would say that there's very few things that I feel like you walk away, from our conferences that we go to where we come back and go, oh man, I'm so excited to start applying this. Well, gut health is one of them. So,
yes.
Okay. So let's talk about when we talk about the gut, again, the reality is people think about our mouth and our stomach being inside our body. They're really not. There's still an exterior surface because if you think about our anatomy, we're really just a large tube.
Yes.
We have a tube on the outside, tube on the inside. Yep. And so from mouth to anus, like if you swallowed a 25-foot string and you just kept swallowing it, eventually that string's going to come, you're going to it's going to come out the other
side.
end. Yeah. And that's still on the outside of your body, right? Nothing's really moved inside.
Right.
So the function of the mouth, besides communicating, is really to prepare the food for swallowing. So we're chewing, and we're supposed to chew, 27?
A lot more.
A lot more than we probably do.
I know I do. That's definitely an area I can improve on.
Yeah. As a resident, man, we would inhale our food because you didn't have like a lunch break.
Yeah.
You may have had like 5 minutes to go grab something to eat. So
Yes.
As physicians, I think we pick up some of the worst habits.
And mothers, where my mom's at, where you're trying to take care of the kids, you're trying to multitask. Next thing you know, I had, how many bites or basically what was my meal standing up.
Right.
Trying to, and of course I probably chewed like 3 times.
Yeah. So when we start chewing, we're preparing the rest of our enteric system. So enteric just means the whole system from mouth to anus. We're preparing it for that food that's coming down. So our saliva, we're salivating. There's enzymes in our saliva that begin breaking the food down. We're chewing. Mastication breaks the food, increases the surface area exposure to those enzymes. And then we actually prepare the food in small little boluses. And the bolus gets to a certain size, and then it makes it so it's easy to swallow. Once it goes to the esophagus is actually designed really for just transmission to the stomach. It's very simple, smooth. It's not the typical mucosa that you have in your mouth, and it's different from the mucosa than you have in your stomach. It's very smooth and slick. It's designed that way so things fall down. So as we come down the esophagus, we get close to the top of the stomach, and we have where the 2 leaves of our diaphragm come together, create the sort of a valve, for lack of a better word, that relaxes and opens up. Food drops in the stomach. And in the stomach, even the process of like smelling food being cooked or talking about food, in other cultures, they'll have a aperitif before dinner that prepares the digestive enzymes. So your stomach starts secreting more acid. And again, all of that is a sensation to prepare. So if we were at home cooking a meal, our stomach is probably getting ready for that food. Whereas we go through a drive-through, we've missed all the preparatory steps.
Yes.
Right? Because our stomach isn't smelling the meat cooking and the aromas and the preparation and all that. So So once it makes it in the stomach, it's mixed with stomach acid, obviously. And there we have other enzymes that come in that are designed to break the food down further. And this is very rudimentary. From the stomach, it passes into the small bowel. And to me, the small bowel is fascinating. And it's actually one of my favorite things. When I do endoscopy, I will go, whether I'm coming from the small bowel, from the colon side or from the stomach side, I like to go into the small bowel, and I'll take a syringe of water and I'll just do a flush, right? And normally people are kind of in a dehydrated state when they come in for an endoscopy. And the mucosa just looks kind of like a cobblestone road. But when you put that water in there, there's actually these villi, just
little
kind
like
of,
finger,
they're like little
projections.
fingers that come up. And what's cool is the water, as you bring the scope in and you put the scope underwater, you actually get a little magnification effect. And so you can see these, and they look like little sea anemones underneath the water. So with that water in there, it's amazing. You can see the villi. What you can't see is the microvilli. So the small bowel, purpose of the small bowel is to absorb all that food, absorb those micronutrients, absorb the food, the proteins, the fats, the carbohydrates that we've eaten. And the absorption surface, even though I can see through the naked eye, through the scope, the villi, what I can't see is microvilli. So each one of those tiny little fingers that's projecting in has millions of little microvilli, little tiny microscopic hairs. And so when you look at the surface area of the small bowel, I think I remember reading that the surface area of the small bowel is equal to 2 tennis courts in an adult, right? And then what's on the other side of that small bowel, that cobblestone kind of appearance, every one of those little bumps in the small bowel is a lymph node. So that is the gut-associated lymphatic tissue, or you'll see it in literature as GALT, G-A-L-T. And really 70% of our immune system, you hear a lot of your immune system in the small bowel. What do they mean? Well, everybody's gotten sick and felt the lymph nodes in their throat get swollen. I probably had swollen lymph nodes when I first had this illness a couple of weeks ago. Well, each one of those little cobblestone bumps in the small bowel is a lymph node. And And so we have the greatest interaction with the outside world, in our immune system's interaction rather, is through the small bowel. And so when you look under a microscope, there's really one cell layer separating you from the inside of your body where the lymphatic tissue is to the exterior where the food is. And again, you're one thickness of a cell away and spread out over 2 tennis courts every meal you eat. So again, I had somebody tell me today that their doctor told them, like, hey, it doesn't really matter what you eat. And every time I hear that, I go, how can it not matter?
Yeah.
How can it not matter?
Yeah.
I mean, especially when you think about Americans today. I mean, 2/3 of Americans are suffering from diseases that are largely caused by
food,
their diet, right? Lifestyle. So anyway, small bowel, amazing absorption area. And for the most part, the small bowel does not have bacteria present. Not a lot.
Compared to the large
intestine, it's we would say it's relatively a sterile environment, unless there is a dysbiotic state, which we may or may not talk about. But so the bacteria that are there are probably transient, because obviously we eat bacteria in our food, whether we like to think about it or not. Sometimes purposefully we're eating bacteria in our food, like the fermented foods, kimchi, sauerkraut. So then once we go through, 22 feet of small bowel?
It's a lot.
It's a lot.
Long.
You make it into the colon. And the colon, I think, is really, for me, has been, I think, the place where you have the greatest mystery going on there. Because that's where that's most of where our bacteria are. And
trillions.
Trillions of bacteria.
Trillions.
And trillions is a huge number.
Yes.
So trillions of bacteria in the colon. And what gets passed into the colon is kind of a liquidy effluent that is really nutrient depleted.
Yes.
Or should be.
Should be.
Yeah. So we should have gotten everything we're going to get out of our meals, and what we're passing on to that bacteria are the things that we can't digest. So the fibers from fruit, fibers from vegetables, whether they're soluble or insoluble. And those are the things that those bacteria thrive on. So in the colon, the main purpose of the colon, besides being a home for those bacteria, I would say structurally the colon is designed to resorb water. So I kind of think of like it's the water reclamation plant for your city, right? It's where the water, all the wastewater comes in, you clean the water and you put it back in the body. So when we're dehydrated, for instance, your body's going to really pull a lot more water out of the stool. And so that can actually make your stool really firm, dried out, little tiny rabbit pellets. Sometimes that's a hydration problem. Sometimes when your body has something in there that's a foreign agent, let's say a bacterial infection in your colon, your body's like, we got to get this out of here. So it does the opposite. It actually says, we're not going to absorb a lot of water. We're going to let this water pass right through you, and that would be diarrhea. So that is, for me, the main function is to get rid of the waste, the things that we can't use, and then to absorb the water. Now, along with that, the bacteria produce lots of beneficial products. In fact, one of the most important products that bacteria produce for us when we're born is vitamin K. So we're all born with a relatively low vitamin K. And vitamin K comes from the gut bacteria. They produce that vitamin, and then we reabsorb that. And that helps us with clotting, a few other things. Our gut bacteria make short-chain fatty acids, but our gut bacteria also communicate with our brain, which again is wild to think about.
Yes.
And there, I would say there's not just bacteria there. There's also yeast, right? And I think this is something I remember. It was Dr. Perlmutter said. I think you were at this conference with me, and it was kind of a mic drop moment. But he goes, I know a lot of you guys are out there trying to get rid of parasites. And he goes, I don't know if that's such a good idea. And then he just ended his talk, and everybody was
like, what?
What is he talking about? But I think what he was trying to say is that for all of humans' existence, parasites have probably existed with us. And there may be, just how like we have beneficial bacteria, there may be beneficial helminths.
Yeah.
Right? I mean, Duke University has done the study on what's the name of the little bacteria or the parasite? It's a rat tapeworm.
The HDCs, the helminths.
Hymenoptera diminutus cysticercoides. So they did a study years ago about this and found that actually when humans are depleted of this particular, it's a non-pathogenic parasite. that their immune systems didn't function properly. And it was almost like the immune system needed that Hymenoptera diminuta cysticercoides to be there, kind of like target practice. So the gut brain, I think, still a mystery there. But again, those short chain fatty acids, I mean, they have shown studies where they have taken fecal material from somebody who is an anxious person, or no, this was done in mice first. I think it was later repeated in humans, but for sure in mice. I don't know how you tell whether mouse is anxious. I guess they're running around looking for cheese all the time.
There are signs.
There's some signs.
There's usually a cat nearby, or
they're just a little jumpy. And so they would take the bacteria out of the mouse that was anxious, put it in a mouse that wasn't, and that mouse became anxious. And conversely, the mouse that was calm, like propionate, is a short chain fatty acid that's calming. And so they put the bacteria from the mouse that was calm into the mouse that was anxious, and it made the anxious mouse calm.
Yes.
So
yes. Well, I think that's a really good summary, but I think it would be fun to kind of go back a little bit through some of those different areas and maybe just point out some other important pieces for our listeners. So I think you covered the mouth piece really well, the chewing piece. I mean, so important, like you said, breaking down, getting that surface area increase, starting to release some of those nutrients that we know eventually, like you said, in the small intestine are going to get absorbed, right? And of course, like you mentioned too, the saliva actually does contain enzymes that get that process going as well.
Yeah,
right?
Amylase.
Yep. And then once we, get down into the stomach, I think, one thing you mentioned that I wanted to come back to emphasize for our listeners is the stomach acid component, right? Because so often in different aspects of medicine and healthcare, stomach acid is made to be a bad guy.
True.
Stomach acid is bad. We have so many medications on the market. Now, several of them over the counter. So patients don't even need doctor's guidance on maybe true risks with some of these medications. And we're told that, hey, stomach acid, can cause, and to be fair, yes, stomach acid in the wrong place can potentially cause some damage that needs to be addressed.
Well, yeah. So you're talking about a class of medications called PPIs, or proton pump inhibitors. And I think, I love Thomas Sowell. I love this guy's an economist, and he's just so wise. But he has a saying that he says, in life, there are no solutions, only trade-offs. And I think PPIs for a lot of doctors seem like a solution, but there are trade-offs.
Big ones.
Big time. So, the solution, one thing that's amazing about PPIs is you rarely have people dying from bleeding ulcers in the gut. I mean, that was a gastric ulcer would cause someone to bleed out rapidly. I mean, that was not uncommon. And I think that is fairly uncommon now because of PPIs. So in a way, you could say that those were amazing, life-saving. But you do have to remember that acid has a very important function. Yes. And not just in breaking down the food, but it's also to kill things.
Protection,
yeah. So as we use PPIs, we see more, maybe we're not absorbing our minerals as much. We're not breaking down the food properly. But more importantly, we're not killing the pathogens that get passed on.
I've absolutely seen this in the clinic. And we do have, I think, data to support this, that long-term use of PPI, or proton pump inhibitor medications that essentially are reducing the amount of stomach acid that you said then can lead to some of these like nutrient deficiencies, can be correlated with things like low bone density. I have absolutely treated patients in the clinic that very quickly after starting these medications came down with intestinal infections, C. diff. Again, maybe made them more susceptible to like some of the microbes associated with food poisoning. But, I don't think that's probably listed anywhere, or maybe it is in very tiny small print on some of these medications. So I don't think patients are, truly being informed.
Well, actually, when you look at something like omeprazole, which is a generic PPI, it says on there, don't take for more than 2 weeks. We have people taking them for 2 decades.
Yes.
What I think what's fascinating too is that, again, we always think of like, okay, well, if you have heartburn, you must have too much stomach acid. Therefore, let's suppress the stomach acid and we'll fix the problem. Yes. And I think there are a fair amount of people who have heartburn from actually I would say a dysfunctional stomach acid. As we age, we don't secrete as much stomach acid. Our stomach acid the pH isn't as low as it used to be when we were younger. So if you have something that is supposed to dissolve food, break it down, the stronger the pH, so lower the pH, the faster it can do that. If you have a weaker pH, your body has to secrete more gastric juice to do the job because it's got to get the job done. So I think there's a fair amount of people that have heartburn that are actually secreting a higher volume of weak acid.
Yes.
So they're secreting their acid for a longer period of time, and the more volume they have, it's just splashing up into the esophagus, and that's what's causing their heartburn. And in those patients, you can actually, it sounds very counterintuitive, but you can actually give them extra acid with meals in the form of, you could use apple cider vinegar, which is an acetic acid. It's a little weak, but it works. You could use betaine hydrochloride, which is a much stronger acid. It's available as a supplement over the counter. And so we will have people who will take extra acid and their heartburn goes away. And you think, how is that possible? Heartburn's supposed to be from too much acid. So again, I guess it's one of these things that the more you learn, you realize it's just not as simple.
Well, and nobody's asking why, right? Like we should go back to even the cases of these people who end up with bleeding ulcers. Why? Why do they have a bleeding ulcer?
Yeah.
Well,
in a lot of cases they were on ibuprofen or they were taking aspirin for, and then that's decreasing their protective lining of the stomach. So,
the way sometimes I'll describe it to patients in the clinic is that, your stomach was designed to be an acidic environment, right?
In fact, I think compared to most mammals, I think we have one of the most acidic stomachs.
A lot of times what happens, obviously like gastritis, inflammation of the lining of the stomach is a very real thing and can cause very uncomfortable and even painful symptoms for people. This can be a cause of, stomach pain, digestive issues. And what I try to help them understand is we need to find the thing, and oftentimes that's plural, not singular, right? So the things that are driving the inflammation in the stomach so that the barrier improves. And then that stomach acid that's there doesn't hurt anymore. Because sometimes, rightfully so, people are like, yeah, but I tried that over the counter omeprazole and I felt a lot better. Yeah. So I'm like, think of it this way, because many of us have probably had a situation like this where, or us ladies who shave our legs, especially if you happen to be traveling and you're in the ocean water is very salty, right? And so if you have a cut on your leg or even sometimes just shaving, you go right into the ocean and that salt water. So again, the skin barrier is compromised. You feel it. It stings. So similarly, I think we can think about that stomach lining in a similar way where it's like, we got to find the things or whatever it is that's causing the inflammation that's essentially compromising the tissue integrity. Yeah. And then that stomach acid's not going to hurt you anymore in how they have, the symptoms of gastritis or that type of thing. Yeah. So,
and chronic stress can make you
100%
have that can be a reduction in your barrier. And so how many people are chronically stressed? That's a big problem.
Huge. Okay. So that's kind of stomach. Let's go back to the small intestine because I agree with you. Small intestine is fascinating. There's a lot of stuff happening there. Yeah. I know we're focusing mostly on the gut, but I think we'd be remiss if we don't say as part of the digestive process, we are getting enzymes from the pancreas that are entering the top of the small intestine and also getting bile that is essentially made in the liver, stored in the gallbladder for those of us that still have a gallbladder. If you don't have a gallbladder, essentially what happens is you still have a tube, a connection from the liver to the small intestine that essentially is just trickling in bile, right? Instead of having a controlled organ that's squeezing it in the presence of food.
Yeah, you no longer have the on-demand system, because there's hormones in the stomach that communicate. Yes. Cholecystokinin is a hormone that says to the gallbladder, squeeze. Gallbladder's a little muscular bag. Yeah. And so, when that bile comes in, that bile salt's purpose is really to break down fat. Yeah. Into really tiny little particles called micelles. And then those actually get taken up under a different absorption system called the lacteal system, if I'm remembering correctly. But bile is really important. And so bile, that's another supplement that sometimes, like the case we presented today where we had a patient who we did a fecal analysis and found out that they had a high steatocrit. So steatocrit is a way of measuring how much fat is left over in the stool after it passes through. It should really be ideally, I think under 18%. And that patient's was close to 60, if I remember, or most 40%. So clearly they were not breaking down fat.
And absorbing it. They were not, it was
and therefore they're not
malabsorption.
absorbing. And that means you're also probably deficient in fat soluble vitamins.
Right.
So how many people are walking around with vitamin D deficiency, vitamin A deficiency, all of the fat soluble vitamins. So if you aren't breaking those down, then bile acid taken as a supplement, you often see it as ox bile, which really is just bile from a cow's stomach or a cow's gallbladder. That can be taken as a supplement so that you are able to break down your fat. Yep. And then digestive enzymes, to bring that up, that's another one that some people have. The pancreas has two functions, endocrine and exocrine. Endocrine, meaning it's making something that's being distributed throughout the whole body. So that's insulin. Insulin's one of the things. And then exocrine would be the things that it excretes into the gut. And so that's our enzymes that are further breaking down the food. But as we age, again, some people have a lower function in their pancreas. We call that pancreatic exocrine insufficiency. And that, again, there are supplements. There are drugs also that can help with breaking down those, like they're pancreatic enzymes.
They're enzymes.
Supplements.
Yeah. Even they're regulated as a medication, but it's technically an enzyme.
It's an enzyme.
Yeah.
And so again, these are all things that when we have someone coming in and they're having gut problems, they say
you got to
think about every step. Yeah.
The lining of the small intestine also produces different types of enzymes that help us break down different types of, carbohydrate structures and things like that. And then, of course, our microbiome. The microbiome, like you were mentioning about fiber and things, it definitely plays a role in digestion and is important for digestion. And we know that when these normal processes that we're describing aren't working as well, absolutely can lead to dysbiosis or an imbalance of our microbiome. So it's pretty fascinating, at least just what we know. There's probably still a lot we don't know about some of these processes too.
So much.
Yeah. So much.
Well, and the other thing I think is fascinating is to think about that most of the volume of the stool that you're passing is actually dead bacteria. That's a lot of bacteria.
So weird.
So let's talk a little bit about a healthy bowel pattern, because I think a lot, people don't talk about their poop enough. But you have a book in your room.
I have a poster in my room.
You have a poster in your room.
A big poster. It's the Bristol stool chart. So it's technically a medical tool.
Yeah.
It's not like I have weird pictures of poop on my...
But it's a scale 1 through 7.
Yes.
Starting with what looks like little rabbit pellets going all the way down to what's just watery diarrhea. And I feel bad for Bristol in the UK because it's probably a lovely town. All they're known for is this poop chart.
Are they though? Or is that just us?
I mean, maybe so. I don't know anything else about the town of Bristol other than this poop chart.
Yeah.
And then I would say the other thing that is as important as understanding what's normal. And this is kind of a funny story, but I had a mother and her daughter come in, and they actually drugged their 16-year-old son/brother into the appointment. And, this poor kid, he's sitting in the exam chair, and the mother and the daughter are over sitting on the couch, kind of how my exam rooms were set up. And I said, well, what are we here for today? And they pointed at him. They go, he has got a problem. He's going to the bathroom all the time. And so I was like, okay, right. So are you having any pain? No. Any blood in your stool? No. Is it watery? No. Are you having diarrhea? No. So how often are you having a bowel movement? And he goes, I have probably 3 times a day. And I was like, oh, and the mom and the daughter are going, see, he's pooping all the time. And so I looked over them and I go, well, how often are you having a bowel movement?
Yeah.
And she goes, like a normal person, once every 5 days.
Oh, God.
And the daughter's shaking her head like that. And I looked at the kid and smiled, and I go, you guys need to switch places. So why was he normal? Well, one of the things that happens when food enters your stomach is you get a gastrocolic reflex. And we were talking about this in our meeting today. There's a reflex, meaning that the brain is not involved. So it's monosynaptic, one synapse. So there's a nerve that goes from the stomach to the spinal cord to the colon, and essentially says to the colon, make way. There's a meal coming. So you better start kicking whatever's there, kick it out. And so the colon starts squeezing, and the muscle the muscular system of the colon is also amazing. We haven't talked about that, but
Yeah.
the fact that things reliably move in one direction is really cool.
And thank God.
Thank goodness, right? Because if it went the other direction, you'd have some problems.
Have some problems.
So what he's experienced is 3 times a day he's having a meal, and about 30 minutes after the meal, you should have an urge for a bowel movement. Now, as humans, we can control that part. And, after we get past our toddler years, we're potty trained. And that's essentially your brain squeezes, it goes into the rectum. The rectum says, hey, I'm full, better find a toilet somewhere. And if you ignore that, then, your colon stops telling you and you have to wait for the next meal. So I think my theory is these 2 women had, and this is actually something I see more commonly with females.
Yeah.
They had just learned to ignore their gastrocolic reflex.
Yeah.
So they were not feeling the urge to defecate. And I joke and I said that I think that's because women are home field advantage poopers, right?
Most women just only want to poop at home.
Oh, and I remember as a resident on the OB floor, the nurses, they had a system for when one of them needed to go to the bathroom. It was like a hidden signal that no one else could go. And there was some bathroom on some deserted wing of the hospital.
Nobody knows about the secret bathroom.
And they were like, everybody knew, like, okay, if they're going, nobody can go. You got to wait until they come back, and then we'll send in another one. So home field advantage, they don't want to poop at school. They don't want to poop at another person. Whereas men, we think about, first thing we get to work, we're like, going to go poop. We get paid to poop.
Yeah.
So I don't think guys have as much of a problem.
No, they don't think about it like that.
But that was really funny. That kid had the biggest grin on his face.
He was so thrilled, I bet.
Oh, he was so happy to know that he was the normal one.
It.
And the mom, when I told her that she really should be having a bowel movement at least every day.
Yeah, I mean, we've gone to some of these, dinners of sorts where some specialist is talking about different types of medications, and I feel like we went to one where they were talking about a drug that was used to treat constipation. Yeah. And I remember listening to the gastroenterologist talk about how, hey, this drug, it had great results in the trials. It took, people who were having, like 1 bowel movement a week up to like 3 bowel movements a week. And I'm just sitting there like scratching my head a little bit going, and he's talking about how it was just so great in his clinical practice. And I'm like, okay, buddy, either I don't know what kind of patients you're seeing that are happy with that. And 2, maybe you're just not listening to them. I don't know. So I raised my hand and I'm like, but don't you think, like, shouldn't people be having at least 1 bowel movement a day? And this guy seriously was like, no.
Yeah.
No.
Yeah. In gastroenterology, actually, the area under if you look at the normal distribution of the curve, it's a bowel movement. It's anywhere from 3 per day or once every 3 days is considered normal.
Oh my.
But again, that's a giant area under the curve. And so I always like to go back to physiology and go, the gastrocolic reflex is there for a reason.
Yes.
Right. Yes. And so for us, we often talk about what's normal on a lab and what's optimal. So, okay, a bowel movement once every 3 days is technically normal by the American Gastroenterological Society's rules or whatever.
Yeah.
But what's optimal is 3 times a day. And at the minimum, when we say at least you should be taking the trash out once a day.
Once a day. And again, I mean, myself included, TMI for a lot of our listeners, but I know a lot of our listeners also feel terrible. They're coming in complaining if they're uncomfortable if they don't have at least 1 bowel movement a day.
Well, yeah, I mean, it actually can be dangerous. I mean, if you're not having a bowel movement, there is a point where you become toxic. And because again, remember the colon's job is to reabsorb water. Well, there's a point where you
like
cross,
what else is getting reabsorbed?
What else is getting reabsorbed? So having that healthy movement through there, is super important.
Yeah.
Okay, so we're in the small bowel still?
Yeah, we're in the small bowel, but I don't know. I mean, you've mentioned, like you even just said, kind of once we get to the colon, we're not really in like a digestion phase at that point, right?
And I skipped over the ileocecal valve, which I think is important.
Yeah, go ahead.
So ileocecal valve is again another valve, kind of like the 2 leaves of the hemidiaphragm coming together at the top of the esophagus, the cardia of the stomach. You also have a valve before the liquid that comes from the small bowel is introduced into the cecum, which is the first part of the colon. And that valve is actually lymphatic tissue. And it kind of, when you look at it in an endoscope, it kind of looks like a fish mouth.
Mm-hmm.
It has like it's kind of a fish mouth that's closed most of the time. But as you sit there and if you take time and watch, it'll open up and...
Kind of like a fish mouth.
Kind of like a fish mouth, yeah. And you can actually have, so just like you can have reflux of acid back into the esophagus, you can actually have reflux of that liquid fecal material back into... And again, that's an area that's rich in bacteria. And that's also where your appendix is, by the way. That little flappy, dangly thing that nobody needs anymore.
Yeah, that doesn't matter.
It turns out that's an important structure. That is probably the seed of it's sort of like our original library of
blueprint of your microbiome.
It's a blueprint of your microbiome. If you wiped out your whole microbiome, you theoretically could rebuild it from whatever's in that little appendix, assuming you still have your appendix. So I think function of the ileocecal valve is something we don't talk about a lot, but now there's people who are really getting into understanding, well, what is the function of the ileocecal valve? Can we improve the function of the ileocecal valve? And so I think there's just a lot we don't know about it.
Right.
But yeah, so then that brings us into the colon. What else did we want to say about the colon? Did we cover
Well,
everything?
I think there's definitely some things we go back to. But let's touch base for our listeners too. We've talked a lot about the function, but let's talk about like what this means for them clinically. Like what are they experiencing or what could they be experiencing in their day-to-day life? The actual symptoms of like what's considered. So we've kind of talked about like, okay, this is what a normal bowel movement pattern looks like. But when we're talking about, because so often, so many people experience symptoms that are just like, even doctors do this. They'll be like, oh, that's normal. Yeah. It's not normal. It's common. There's a difference. So,
that's a great point.
Let's go through some of the things that like, hey.
So before we talk about dysfunction though, we probably should talk about what a normal person should feel like after a meal. And this was a powerful lesson. So I had the privilege of being in the Xifaxan clinical trial as a principal investigator for that. So that's the antibiotic that you were referencing before that we used to treat SIBO. And in that trial, the specific trial we ran was the retreatment trial. So people who had failed the first treatment came in for a second. So in that trial, it was amazing because we would have to collect from people like, what are your symptoms before? And oftentimes they would say, they might not report any symptoms. But there were quite a few people that when they came back after being treated with Xifaxan and that had cleared up a problem for them, they made this comment. And I remember this comment said over and over again, people go, oh my gosh, I have no idea this is what a normal person feels like after a meal. And so they had what they had thought was normal was just something they had experienced their whole life was that they would eat and they would have bloating and cramping and pain. They just assumed that everybody has bloating and cramping and pain after a meal. And it wasn't until they cleared out the bacteria in the small bowel and they treated that small bowel overgrowth that they were like, oh, no, that actually isn't a normal thing for people to feel. So again, I think the normal thing is we get hungry, we make our food, we sit down, we chew slowly. We enjoy. I mean, in other countries, I don't know if you've traveled to other countries. When you sit down in Italy for dinner,
you're sitting down. You ain't going anywhere for a while.
And that waiter knows that's that.
They're
table,
like, I'll be back in an hour.
That table's going to be here all night long. So they just know. They slow down. They talk. The meal is an event to experience. It's not something to get through quickly. So I think that's something us Americans could probably learn. But so we're sitting down, we're chewing, we're taking time, we're resting and digesting after the meal. So people often will just socialize, maybe go for a light walk, kind of allow that food to break down. And again, you should not have diarrhea right after your meal. You should not have bloating, cramping, pain after a meal.
You shouldn't have difficulty with swallowing. You shouldn't feel like you're choking. You shouldn't feel like stuff gets stuck. You shouldn't have pain with swallowing. You shouldn't have burning or, a warming sensation or anything like that, like especially in the upper part, right? Closer to like your chest or your throat, right?
And then 30 minutes after the meal, you should probably feel the need to go to the bathroom. And so for some of our patients who have forgotten what the reflex feels like, we'll tell them to go perch. Get on a bowel program.
Bowel training.
Bowel training. So you go 30 minutes after a meal, you set an alarm, and then you just go sit on the toilet. Not for a long time. It's just more to kind of train your body that, hey, remember what this is for.
Yeah.
But I think that's normal function.
Yeah. And gas. I mean, let's talk about gas a little bit because I think there's a balance, right? There's probably a sweet spot when it comes to gas because a very healthy, normal microbiome will produce gas, right?
2 liters of gas a day.
Oh, sounds like a lot. So
Some people are gassier than others.
But probably it's not, we wouldn't consider it normal if somebody's like, wow, I am belching all the time, or I belch a lot after I eat or drink.
Right.
Again, like you mentioned, not normal to feel super full or bloated. Or sometimes people, they'll describe it more of like a fullness or that they just, a lot of women, that have especially been pregnant, they're like, I feel like I'm like 6 months pregnant. It's always 6 months too, by the way, which is, I think is kind of interesting. But things like that are not normal. Feeling full if you've eaten too much. Okay, well, that's arguably, an expected response.
Well, and one thing we glossed over is, again, we call it the small bowel, the large bowel. I mean, the small bowel is much smaller in diameter. And so, and it's longer than the colon. And so when you have bacteria present there that aren't supposed to be there, maybe they've set up a colony in the small bowel, then the food that you're eating that you're supposed to be absorbing and digesting, now the bacteria are getting access to it and they ferment it. And that fermentation produces that gas. I mean, if anybody's ever made kombucha at home, you always got to have that little thing to kind of
got to burp
out the extra gas. So when I hear someone who says they have a lot of burping soon after eating a meal, that to me says probably they have an excess gas production in the upper small bowel. When they say they just produce a lot of gas from the other end, flatulence. Right? We got eructation and flatulence.
What did you call it today in our meeting?
What did I call it?
An air biscuit.
Yeah, we were talking about sulfur air biscuit, floating an air biscuit. I don't know. That's something we said as kids.
Sorry, I just had to. It's so funny.
So there are really 2 predominant sources of gas in the human body. And one is swallowing. I think swallowing is one that's not often recognized.
Yeah.
Because we do swallow a little bit of air with every gulp. So some amount of gas, a little burp here and there is not, I don't want people to run to their doctor and go,
just because,
oh my gosh, I'm burping
belched
after a meal. And I heard Dr. Marvin say that you're not supposed to burp after a meal.
To clarify, if you rewind, I said it's not normal to burp a lot.
A lot, right. And what is it Japanese culture where it's actually a sign of respect to burp with a meal, or maybe it's Chinese culture?
It's some
there
culture.
Is a culture
I don't know
where if you let out a big belch, that's like,
hey,
I like the meal.
I like the meal.
Yeah.
It's great.
So swallowing air. So if people have postnasal drainage and they're constantly swallowing, they can actually have a lot of gas production.
Oh, okay. Pause for a minute, because when you say that, that's another symptom sometimes that people don't realize it's digestive in nature. It feels like they constantly have to clear their throat.
Tell me more.
So that can actually be a sign of reflux. Irritation, back up. Now, we live in one of the top allergy centers, cities in the United States. So sometimes I do have to try to figure out with people, okay, is this coming from up top or is this coming from, because, people, especially a lot of people again in this area, they're like, yeah, I'm on all the Claritin, all the Allegra, all the nasal sprays already. And they still have symptoms. So that is something to pay attention to, especially after eating, especially after drinking certain things, especially things like coffee, alcohol, soda,
Well, yeah. And alcohol. So one of the things that alcohol does, again, to that little sphincter at the top of the stomach, alcohol relaxes that. Nicotine relaxes that sphincter. Peppermint and spearmint relax that sphincter.
Yeah.
Eating a heavy meal and then going and laying down can make that heartburn worse. So I've always said, if you want to have the worst heartburn ever, go eat, pizza, smoke a cigarette, drink a glass of wine, and pop a dinner mitt and go lay down. You'll have terrible heartburn. Oh. I don't recommend anybody do that, but just an example of all the things that you could do wrong. So so just like that burping, the excess production, I think a lot of people who have SIBO, their presenting symptom is heartburn.
Sometimes.
Right, because you're bubbling all that gas up through the gastric acids.
Yeah. Well, and that's a good point to also draw attention to, that just because you don't maybe have some of these more classic textbook types of symptoms, right? When we're talking about some of these, what are arguably abnormal or not normal symptoms, doesn't always mean that the gut is still in good shape. Sometimes there are some weird, or just what we feel like are weird, or just not the most common symptom presentation, or where the patient will actually present with a specific type of condition where we have come to understand that there's a very close connection to the gut, right? Yeah. So like you mentioned earlier with the immune system, right? The majority of our immune system being in the gut. This is why any patient with an autoimmune condition that walks in our door, we are asking about the gut. We're looking at the gut, doing, like you mentioned, fecal microbiome testing or breath testing, those types of things. Yeah. Because sometimes, it's things like Hashimoto's where we know that there's potential correlation with things like H. pylori overgrowth or even yeast overgrowth or strep, which is a type of bacteria overgrowth. Again, we're not saying that's the only thing that triggered that condition for that patient, but we do find in the literature these strong correlations with these conditions in people that have certain types of autoimmune conditions.
Well, and I would say it goes even further than saying it's a strong correlation. I think that mechanistically there is a path that makes a lot of sense when it comes to the gut. So again, we talk about that tennis court surface area, half the width of human hair, away from 70% of your immune system. So let's talk a little bit about when we talk about leaky gut, which a lot of our doctor colleagues, they roll their eyes like, oh my gosh, leaky gut. That's
maybe less so now. Definitely like 10 plus years ago when we would be going to some of these, either talks or conferences.
Nobody believed in leaky gut.
Everybody was kind of like, what?
Yeah, your gut doesn't leak. And so I think for me, listening to a guy like Alessio Fasano, who is an amazing researcher at Harvard, discussing in his lab what he's learning about tight junctions at the cellular level. He's the one that his lab discovered zonulin, which is a protein that gets exposed when, you think about those microvilli, those cells. If the microvilli in my fingers and my palms are tight together, the tight junction is supposed to seal so that everything has to be absorbed through here. Well, what happens with leaky gut is we get a compromised barrier. And now those proteins, instead of being absorbed into the microvilli, being processed by the cell and then presented to the serosal surface of the cell, mucosal serosal, they are passing through in large part probably unchanged. Unchanged. So now those food particles are now having access to the immune system. They're in an immune privileged space where they shouldn't be. Well, your immune system's function is to decide what is you and what is not you. When an amino acid, a fatty acid, a vitamin, a mineral comes in, your immune system isn't reacting to those. Our immune system never reacts to those basic building blocks of life. But if an egg protein comes across, your immune system is going to look at that and go, well, that's not supposed to be here. So what does it do? It makes an immune response. So we get an immunoglobulin that's formed. That immunoglobulin then attacks, neutralizes the egg. Again, in some cases, this might be an allergic reaction, but a lot of times it's just immune dysregulation. It's not.
Well, it goes back
a hyperimmune where you're getting like your throat swelling or your lips swelling or your tongue swelling or hives or itching.
Sometimes you do.
Sometimes you do.
But it goes back to your point earlier when you were highlighting the cell layer, the single cell layer barrier, which seems, in some ways it's like, oh gosh, that does really arguably leave the system very vulnerable. But then when you throw in that the majority of the immune system is there, kind of like you just referenced, it's like the army that's there to protect you.
The guards
then
are
it makes
on the
a lot
wall.
of sense.
Yeah.
It makes a lot of sense.
It's like
right?
if we had a border between us and a dangerous country, where would most of our military be?
Right at the border.
Right at the border, right? They're like, well, these are the guys that are trying to kill us.
Right.
So we're going to station ourselves right on the other side of this wall. Right. And so that leakiness isn't really a leaking like a sieve. It is a molecular excess permeability.
Yeah.
And so I think when you look in the literature just describes it as abnormal gut permeability. And that in essence is what people are calling leaky gut. So
that is a pro tip. If you're ever talking with somebody, especially a medical professional, use the term intestinal permeability. It's a lot less triggering.
Yeah. But so again, mechanistically, what's going on? So you're having these proteins that are non-harmful for the most part, leaking into the privileged immune space. You're getting immunoglobulins being produced. And the problem is the more immunoglobulins you're producing, you can get into a condition called molecular mimicry, right? So if you make an immunoglobulin and think of it kind of a lock and key structure, you create a key that can unlock a certain lock, but sometimes that key might work in multiple locks. And so sometimes that immunoglobulin that is attacking the albumin of the egg that's coming across could potentially also attack your thyroid, right? And this is why we see for wheat, right? A lot of people who
Yeah,
have
there is evidence for that. And gluten, the protein gluten.
right? So the protein, gluten, and wheat, that there is absolute evidence of cross reactivity of that gluten immunoglobulin with your thyroid gland. And so again, why is it so important that we put people on thyroid replacement that's gluten free? Because a lot of our thyroid patients react to gluten.
Right.
So that mechanistically, I mean, again, it's not just a correlation. There is a very, from a basic science understanding, we understand that molecular mimicry can create crosstalk where now your immune system is attacking you.
Yeah.
And that's autoimmune disease.
Yeah.
Right? It's a misrecognition of your own self as an invader.
Yep.
And so I think the stronger our gut barriers, the more or less permeable it is, the less likelihood we have of creating those potential immune reactions that we don't want.
What are some common conditions that you see come into the clinic where you're like, oh, this definitely is connected to the gut?
Well, like you said, with any autoimmune disease, we immediately I mean, we're gonna look at a lot of things, but the gut was going to be probably the primary thing that we focus on.
Skin, eczema, psoriasis,
allergies, asthma, eczema. Yeah, your skin is a mirror of what's going on in your gut. Joint pain, inflammation,
headaches. Yeah, for sure. One thing you referenced earlier, we should probably circle back to, kind of in this vein of just the connection with the gut and how it's connected to all these other areas, is I want to go back and talk a little bit more about the nervous system component with the gut, because the gut is so heavily innervated. I talk to my patients about this all the time, because sometimes people will look at me and be like, I know this sounds crazy, but I've really discovered this correlation with like this kind of like emotional stressor, or some patients even are just like, I just am trying to leave the house for the day and my gut is like going crazy. Like, what's going on? And there, of course, and rightfully so, everybody should be questioning things like, was it something I ate? Was it a supplement I took? Was it, this, that, or the other? But sometimes people, when it comes down to it, they're like, I was fasting. I didn't take anything. I was going to my fasting lab appointment, all these different things that they've tried to figure out, like what is triggering my gut. And so many times we're able to tie it back to the nervous system. And I think, again, when we kind of start to talk about how it's like the gut being heavily innervated, the gut even having its separate innervation from the brain. So if that line of connection, through like via the vagus nerve, for example, coming from the brain stem, going to innervate the gut, was severed, the gut is still innervated by the enteric nervous system.
Right.
That's like a gazillion. I mean, it's not a gazillion, but it's many, many, many neurons in these nerve cells that essentially keep it doing things.
Well, the ancient Greeks thought that the seat of human emotion was in the gut. Meaning the brain. And I remember, I had a German anatomist in med school, and he used to say, "The gut is the second brain." And I never really understood what he was talking about. The gut. And, some of the same neurotransmitters in the brain we find in the gut. And that doesn't mean that the gut is producing serotonin that goes to the brain, but the serotonin is having a similar function. There's a lot of serotonin made in the gut.
Yeah, it's important to remember there's peripheral response from like neurotransmitters are not just inside the brain.
Right.
And
so when people feel anxious, they have a bowel movement, right? And you and I graze animals. What do you see with your animals get startled?
Oh,
they poop.
It's like every time I try to get my cow into the stanchion, she starts pooping. I'm like, okay, really? I'm just trying to milk you. I'm not being nice. I'm giving you a treat, you know? Right. Oh yeah, animals trying to load them in a trailer. But yeah, where do you think all these phrases came from? Go with your gut. What's your gut tell you?
Yeah.
What's your gut feeling?
Right.
Yeah. It's a very real thing. So
Yeah.
I think it's a very valid and again, humbly saying, like, to the extent that we can as human beings understand it, makes a lot of sense. I give a lot of validation to my patients who are just like, I know it's like people just keep telling me it's in my head. And I'm like, no, it actually is in your gut.
Well, yeah, no, I had a patient today that I was on the phone with her, and she's going through a tough spot. She's got, a breast biopsy that she's waiting to do, and she doesn't know what the outcome's going to be. And of course, she's just, her husband had a lung biopsy, so a little bit of a lung cancer scare, and and so she's just in tears. And then she says, and I have this diarrhea several times a day. And I went through and made sure. I'm like, okay, well, there's no
Still
blood in your
ask questions,
diarrhea.
right.
Yeah, is it?
Still got to ask questions.
Have you taken an antibiotic recently? No, I haven't done any of that. I think this is stress, right? So she's having a stress response. So
yeah, but I think it's really helpful when I explain that to patients, because otherwise, even sometimes when I tell them it's a stress response, they're kind of like, oh, you're like everybody else, just thinking I'm crazy or in my head. So I really make a point that they understand
there's an
that
actual connection,
and that I'm validating that,
Yeah.
and that a lot of times that's a missing component. It's like we optimize digestion, we optimize their diet, we sometimes use probiotics and all these things that a lot of people in today's world know are good for the gut, and they still have symptoms.
Right.
That last remaining piece can sometimes be, I need to regulate my nervous system. And then those bowel movements and digestive symptoms fall into place. So just so our listeners understand, and like some of the things, sometimes it's like if patients, and this would be a perfect another case example of somebody coming in where we're going to look about in the gut, anxiety, depression, brain fog, mood swings, right? All those different types of things. Absolutely, we should be asking. Us, we're asking about the whole picture, but absolutely should be thinking about the gut.
Yeah. Okay, so we've talked about gut function. We've talked about things that can go wrong, symptoms that things aren't properly balanced. What are some things that people are doing in their daily life that may be making things worse in their gut that they might not know? Some common things that we do. Bad habits, for instance.
Yeah.
What are some ways we can disrupt our gut function?
Poor sleep.
Poor sleep's a big one. Yeah.
Poor sleep, not getting enough good quality sleep, because ultimately that's certainly a physical stressor on the system.
Yeah.
That's probably even part of the mechanism is how like our immune function declines, right? If we're not sleeping enough.
Alcohol.
Oh yeah. I was going to say beverages. Like when we talk about nutrition with people really hyper focus on food and they don't think about liquids that they're drinking. So, obviously.
And these cans, by the way, this is just salt water.
Yeah.
Flavored salt water.
We're not drinking soda. Although, hey, shout out to some really cool, I'm so thrilled because, it's like years and years ago, even when I was a kid, I mean, we didn't have a lot of these really cool product alternatives,
No.
I mean, like, and of course I'm referencing, since we mentioned soda, like Poppy and Olipop.
Yeah, you had Coke, Pepsi, Dr. Pepper,
yeah.
Mountain Dew.
I mean, I'm looking at this like Olipop label the other day. I think it was the one you had. It was like 9 grams of fiber.
Yeah.
Most Americans don't even get 9 grams of fiber in their food that they eat every day.
Not saying that they should drink a bunch of pop leaves.
Yes, this is definitely not a plug to be like, oh yeah, just drink 4 Olipops a day to get your 35 grams of fiber.
But if you're choosing between a Coke and a pop
leaf, it's like so obvious it's a better
huge
choice.
Difference in calories and everything.
Yeah, like you said, alcohol. I know everybody loves their caffeine, but I do think sometimes coffee, and I'm not even saying caffeine is necessarily the problem. Right. I think there's other things in coffee sometimes that can cause inflammation, mycotoxins, chemicals. I know, because you're a caffeine addict. So go ahead. I'll hear it.
I'll push back only in this, that I would say, yes, I agree with you. I think coffee can be a problem, but I don't think it's the coffee that's a problem. I think it's because it's one of the most heavily sprayed crops.
Well, right. That's why I said,
so agriculturally,
like chemicals,
you're getting a lot. You're getting a lot of chemicals.
Yeah, because most people,
drink organic.
Everybody's lining out the door at Starbucks, which is like, so toxic. If you read my newsletter last month,
you're getting
microplastics,
you're getting non-organic coffee.
Chemicals,
it's going into a cup that's not paper, it's plastic.
That's why
it's plastic lined.
See, the addict couldn't even hear my preface to that. I gave it a preface. I'm teasing a little bit anyways.
Yeah.
Okay. But no, I hear you. Yeah. So liquids, drinks, energy drinks.
How about probiotics? Right? Probiotics are good. Shouldn't everybody be taking massive amounts of probiotics every day?
Yeah, such a good question.
Don't we give everybody that comes in a clinic a probiotic?
Absolutely not. I don't take probiotics.
I don't either.
Anytime I've tried, my gut was like, why? What's this? What's happening?
Well, if you think about it, you're putting a big load of bacteria into, it has to go through that 22 feet of small bowel, and hopefully it doesn't stop and get set up as a colony there.
Yeah.
So if we're going to do probiotics, we probably should do them as rectal probiotics.
That's interesting though, because I think my understanding is of most of the literature on probiotics is that they're not really colonizing. Most of them are not colonizing.
They're probably support for healthy bacteria.
I can't remember where I heard this, so I'm definitely not going to take, I don't want to take credit for it, but just that we can think of probiotics as like travelers passing through. So it's like if, when you and I go on vacation, wherever we go, it's like we're paying for a hotel, we're going out to eat, we're stimulating the economy, and then we leave.
I know where you heard that analogy.
Oh, where? Tell me, because I obviously forgot.
It was me.
Oh, of course. Yes. Please take credit for.
No,
it truly could have been. But
the tourists are supporting the local economy. Yes. They don't live there. They're there transiently, but they are definitely good for the economy. So,
and to go back to like what you even said
earlier.
How
I love analogies.
Yes,
so.
You do.
I feel blessed that you remembered my analogy.
Well, I'm glad you remembered. So. But even how you said like how people are, using like the HDCs, like the beneficial, just they're just traveling through, giving us some type of an immune response that sometimes really helps people if they have certain types of autoimmune conditions or inflammatory conditions. But we don't give probiotics to everybody. We want to be very intentional about them.
We do use them therapeutically.
Yes,
absolutely. So
absolutely.
there are times when probiotics are very beneficial.
Absolutely.
But I think my word of caution would be to people, a probiotic isn't necessarily beneficial for everybody.
Yeah.
And so if you feel worse when you take a probiotic, that's a sign you probably shouldn't be taking one.
Yeah.
And it seems self-evident.
Generally that's good advice.
So then there's antibiotics. So we're going to talk about probiotics. We got to talk about antibiotics.
True.
Fortunately, we don't use very many of those in the United States.
Yeah, hardly any at all, right? So it's really not a big issue.
Yeah.
I wish.
I think, is it still true that one course of an antibiotic can disrupt your gut flora for up to a year? Is that right?
It's difficult. And I feel like, this is something I feel like we run across anytime we're looking into the literature. I feel like I can find studies kind of arguing both sides.
Back and forth, yeah.
So I think, it's fair to say that we do have maybe some literature that suggests that it really can cause some major disruptions. And we've absolutely seen that clinically.
Sure.
Right? I think you're more likely to see that in individuals that are on antibiotics often.
Right.
They're dealing, these, just being here with like the allergies and stuff, people who are just taking multiple antibiotics for sinus infections.
Well, how many patients do have an annual sinus infection?
Yeah. But I like to reassure patients too on the flip side of that, where it's like this really appropriate reason to use this antibiotic.
For sure.
Your gut is more than likely going to do just fine.
Yeah.
Even have some literature to suggest that even if we did nothing, even if we didn't give you a probiotic or, that
your gut will
recover. So, I like to, again, it's like we're being mindful. We don't want to use antibiotics all the time because yes, that can cause disruption, but we shouldn't let that, let us be super afraid to take an antibiotic if it's really, really appropriate to use one. So, let's see, what else do we want to say? I think some of those are pretty obvious for our listeners. Oh, one area I think we should absolutely touch on, gut and hormones, hormone metabolism.
Okay.
We see a lot of patients in our clinic. We do a lot of hormone therapy and support. Uh-huh. And this is another area that, again, going back to our short list that we're kind of creating of conditions, that we see in the clinic that absolutely we need to think about the gut. So especially for women and irregular menstrual cycles, heavy menstrual bleeding, some of these so-called like estrogen dominant types of symptoms, right? The gut is heavily involved in that often, right? I mean, yes, there's other, systems we definitely check in on and we often find need support too. But we have gut bacteria that actually make substances that affect how we metabolize hormones like estrogen. So we were talking about it in our case today even, right?
Right.
We can measure this enzyme called beta-glucuronidase. That is often, we do see that when people have dysbiosis or an imbalance. And essentially what's happening is like when your liver, which is a huge component of the digestive system, arguably, right?
Right.
Is metabolizing those hormones and other substances too. It's essentially kind of like using a little flag system. It's like tagging things where it's like, this needs to go here. We need this back. We're going to send this out in the bile so that we can get rid of it through the stool. Right.
Yeah.
And estrogen is like that. And so if we have our liver tagging this estrogen to leave through the intestines, because it's going out through the bile, if you have high levels of beta glucuronidase made again by that dysbiotic bacteria in the microbiome, essentially is like taking that little flag off.
Yeah. And you're just reabsorbing
Yeah. And then your
that
body's
estrogen
like,
your body's
oh,
trying to get
where's
rid
your
of.
flag? You're coming back in,
Right.
you know? And so I think that's another really interesting connection that we can see with some of our ladies that are struggling to metabolize hormones.
Yeah, that's fine.
So it's so interesting, like all these different areas of the gut. Should we maybe transition a little bit to like, what can we do?
Takeaways.
Yeah.
Gosh, this is the one I probably struggle with the most is like, telling people what to eat. And I still feel like it's just an area of our...
I don't. It's so easy to tell people what to eat. It's if they'll do it. That's the hard part.
Yeah. No, I mean, I just in terms of like the scientific research on what to eat, we really don't have, we have pretty poor research, but I think we have a fairly good understanding from a functional standpoint.
Yeah.
People need to be eating real food.
Yes.
Right. So,
yes.
If you put something on your counter and it hasn't molded or gotten, or spoiled, after 3 or 4 days, probably that's not something we should put in our body. So eating whole food without a label, I think eating a diverse diet, but certainly paying attention to your body. I mean, some people can eat certain things and that makes them feel bad. And so avoid those things, right? I mean, if you can't break down milk, don't drink a bunch of milk and have cheese, right?
Or seek out a good raw source of dairy, regeneratively.
Yeah.
Grass-fed,
raw milk.
Yeah.
Would also be good.
Yeah.
Go back and watch the
because
podcast
people
with
hear
Jayco
people hear that like don't consume dairy. They're like, I'm out.
It's tough, especially in America.
Yeah, for sure.
Yeah, I think eating healthy meat.
Yeah.
Right. I mean, I often say I care more about what your meat was eating than what meat you're eating.
Yeah.
Because a lot of people say, I'm trying to avoid red meat. I don't think we need to avoid red meat, but I think we need to think about where our meat's coming from.
Absolutely. And I think we should, sometimes, this, right? There's different areas of medicine where sometimes it's like the pendulum's over here and then something happens or we observe things that happen. And then sometimes the pendulum swings a little too far. I feel like sometimes that has happened with fiber.
Plant-based diets, right? Everybody's like, I just got to eat all plants. And I'm like, nah.
Yeah, but I don't know. I mean, I think we do have a lot of good evidence that even like we were referencing earlier, that the gut microbiome, I mean, fiber, that is fuel for the gut microbiome. And so sometimes I think, yes, we have certain conditions that some people have where they have a more difficult time with fiber or fiber-rich foods. But I think we should try to look at and address and support those things that we think might be causing the fiber intolerance.
Yeah.
And then come back to it.
I also think the microbiome can adapt too, because we've got patients that, I mean, they don't eat a lot of soluble plant fiber, and they're eating a mostly carnivorous diet and they do really well. And so we got to remember, there's fibers in meat, there's collagen fibers that bacteria can utilize.
Yeah.
It's probably more about being consistent. I mean, again, we think about our ancestors. Our ancestors would have eaten pretty much the same foods all the time. And so in a lot of people that travel, they have dysbiosis when they travel, probably because they're eating a bunch of food their microbiome's not used to.
Sure.
So I do think the microbiome can adapt over time. So having some structure in your diet, trying to eat the similar foods often, there's probably some wisdom in that.
Yeah, for sure. Polyphenols, so these, compounds that we often find in like fruits, vegetables, especially like the ones with deep, rich colors, some good evidence for the microbiome really thriving.
Yeah.
So I think predominantly when people come in and they're like, how can I support my microbiome? How can I increase diversity? A lot of times people are like, what probiotic should I take? And I'm like, well, actually, it's more about food. Feed the garden.
Which is your prebiotic.
Yes.
Yeah.
Yes. So, and again, I think a combination of just like how we treat supplements in the office, we try to prioritize food first.
Right.
But not going to lie, just like, a protein powder can help us reach protein goals. Sometimes a fiber supplement,
or
fiber supplement can really help us with our fiber goals for people that really, helps.
So managing stress, I'd say another big thing that people can do. Making sure you're getting adequate sleep.
Yep.
Movement.
Yep.
So our enteric system needs that movement back and forth. When we're sedentary, things don't move as well.
Yep.
So
I think there's 2 areas I wanted to circle back to with like constipation. I think probably maybe two of the most common causes of constipation that we just generally see in the American public is probably lack of movement and dehydration.
Yeah.
I have been so tickled sometimes when I have clients who are like, never really like the taste of water, or, I just like need something else. And when I'm drinking, and then they find like a filter or whatever it is that just really improve the taste, they start drinking a lot more water and they're like, my chronic constipation is gone.
Right. Well, again, because part of that colon's job is to reclaim the water. And when it has to work extra hard, you're passing on a really dehydrated stool that's hard to pass.
Yes.
And again, the other thing I like to remind people when it comes to hydration, it's not just about water, because water follows salt.
Mm-hmm.
So if you don't have enough salt in your body, I mean, everybody's on these low salt diets.
Well, unfortunately, though, I think most Americans get too much salt because they're eating ultra processed food.
Yeah.
It's like if it didn't have a ton of sodium in it, it's going to taste like cardboard.
Right.
So, I think, yes, some of us who are, it can be, I guess we'll put it this way. When people are really focusing on eating more of a whole food based diet, then sometimes you're right, they are not getting enough salt.
Yeah, so
for sure.
And that's where I would say if you feel like you're drinking enough water and you're still thirsty, you probably need more salt.
Yes, that can sometimes be helpful for sure. Any closing remarks? I feel like I have one more thing I want to say.
I think that the biggest closing remark is we probably do need to circle back on a separate podcast and just talk about leaky gut, its relation to autoimmune disease.
Yes.
Do a deeper dive into SIBO and its interaction.
Yeah,
there's a lot to unpack there.
We really wanted this episode to just kind of lay some ground, some framework, just kind of lay the basics out. We are absolutely going to come back and start to like touch on some things like IBS and SIBO and maybe even like inflammatory bowel disease. And again, I think it'd be great. But do you have anything else you want to say? Because I've been saving something for the end.
I'm done.
A lot of times, and again, rightfully so, like I'm not saying this is wrong, because again, I really appreciate when patients are coming in and they want to understand. They want to understand what's going on with their body. They want to also understand it because when we understand things better, we tend to make better choices that help support to get us to a goal. But sometimes I see this in the functional medicine world where we get caught up in healing the gut, or like, I get patients that are like, how do I heal my gut? I have a leaky gut. How do I heal it? How do I do this? And it's like, the gut I view it as like fluid. And I know that there's things too that, people don't like, we don't have a lot of control if like, kids bring home the stomach flu from school, or you happen to get food poisoning or those types of things. Right. And I just sometimes see this great deal of like stress of like, I just got to fix my gut. And what did we talk about that stress does to the gut? Yeah. It's just going to keep making it more permeable and more inflamed. Right. So I think it's a humbling reminder that like, yes, we want to acknowledge these things. Yes, we want to address them. And ultimately, I think the goal should be, we want to live our life and have lifestyle practices that keep our gut in good shape and good function.
Right.
But also acknowledging that like nobody's ever going to get to a place where their gut is bulletproof, never going to have anything negatively impact them.
Yeah.
I just think that's worth letting people know, because I just see people sometimes like lamenting that like if they just get to this one place, everything will be fine,
Well, the gut wants to heal itself.
Yeah.
And oftentimes
the whole body does.
Right. I love the verse, we are wonderfully and fearfully made.
Yeah.
Our bodies are designed to heal.
Yes.
And if we just take the insult away, oftentimes that healing can happen. And let's not forget how fast the gastric mucosa can heal. I mean, everybody's bit the inside of their cheek before. It creates a little sore there. Yep. But a week later, it's gone. That is your body healing.
Yeah.
So as long as you don't keep biting that same area over and over again, that healing can happen. So yeah, I do agree. I think sometimes people are looking for perfect. Yeah. What do they say? That better is the enemy of good.
Don't let
better be the enemy of good.
Don't let perfect be the enemy of the good.
Right.
So I would just encourage those people out there on their gut healing journeys to just think of it more as like, hey, my goal is to like just optimize my health so that my gut is working well.
Balance.
But also knowing that like I am not bulletproof.
Yeah.
And things happen. And again, when I give my body, not just the gut, but the whole body, the right environment and the right tools, you can get there. you can get back. So
I think that's a good point to end on. Good job. Thank you. See you guys next time.
bye.